1 designated space. Flexible bronchoscopy should be performed in a dedicated area, ideally a specialized suite in a hospital or outpatient facility. 2. Sedation requirements. Intravenous sedation is typically used, necessitating recovery areas for post-procedure monitoring and care. 3. Enhanced capability suites. The optimal setup includes suites equipped for advanced imaging and interventions such as fluoroscopy or computed tomography, CT, guidance, and facilities for administering general anesthesia. 4. Room size and storage. The examination room should be spacious enough to accommodate all necessary equipment, supplies, and accessories without congestion. 5. Adjacent storage. It is preferable to have a storage area right next to the endoscopic suite to streamline operations and improve efficiency. 6. Equipment care. Special holding racks and storage cases are recommended to protect the equipment, particularly to minimize the risk of damage to the scopes. 1. Portable cart setup. Utilize a portable cart equipped with a light source, bronchoscope, and necessary accessories for conducting bedside bronchoscopies. 2. Convenience. The mobility of the cart allows for easy access to perform procedures directly at the patient's bedside. 3. Post-procedure care. After each use, the cart should be returned to a designated storage area. 4. Cleaning and restocking. Ensure proper cleaning of the equipment and restock all used accessories to maintain readiness for the next procedure. Advantages of flexible fiber optic bronchoscopy. 1. Patient comfort. Less discomfort due to the flexibility of the fiber optic scope. 2. Segmental visualization. Ability to visually inspect individual lung segments. 3. Segmental biopsy. Enables taking tissue samples from specific lung segments. 4. Peripheral biopsy. Capability to sample from peripheral areas of the lungs. 5. Transbronchial needle aspiration. Allows for needle biopsy through the bronchial walls. 6. Bedside aspiration. Can be performed at the patient's bedside. 7. Bronchoscopy on ventilator. Possible to perform on patients who are mechanically ventilated. 8. Bypass distortion. Flexible scope can navigate around distorted anatomy. Phenography. Allows for capturing images during the procedure. 10. Increased cancer diagnosis. Improves the rate and accuracy of cancer detection. 11. Brachytherapy. Facilitates targeted radiation therapy via bronchial access. 12. Laser bronchoscopy. Enables laser treatment for tumors and obstructions. Disadvantages of flexible fiber optic bronchoscopy. 1. Small channel. Limited size of the working channel restricts certain tools and maneuvers. 2. Breakdown. Higher susceptibility to mechanical failure and damage. 3. Sterilization. Requires stringent sterilization protocols that can be challenging. 1. Versatility in diagnostics. Flexible bronchoscopy allows obtaining diagnostic material from both peripheral and central lung lesions with minimal risk. 2. Anesthesia safety. Typically performed under topical anesthesia and intravenous sedation, reducing the risks associated with general anesthesia. 3. Secretion management. Retained secretions can be aspirated effectively at the bedside in ward or intensive care unit settings. 4. Ventilator compatibility. Can be used on patients receiving ventilator support without compromising the airway by using a sidearm adapter. 5. Navigating challenges. The flexible scope can pass through narrowed, distorted, or obstructed airways. 6. Lobar and segmental assessment, especially valuable for evaluating lobar and segmental airways in the upper lobes. 7. Documentation capabilities. Facilitates still or video photography during the procedure to document findings. 1. Cough assessment. A new persistent cough or change in cough pattern is an indicator for considering a bronchoscopic examination after ruling out other causes. 2. Wheezing investigation. A wheeze that is unilateral and does not clear with coughing should be investigated via bronchoscopy. 3. High suspicion index. Maintaining vigilance can lead to the diagnosis of tracheal and major airway lesions, even when radiologic findings are absent. Sterile sputum collection. Sputum can be collected in a sterile manner to check for opportunistic infections, especially in immunocompromised patients. 2. Precaution against TB. For patients suspected of having tuberculosis, induced sputum samples using inhaled saline should be examined before bronchoscopy to prevent contamination of healthcare workers. 3. Therapeutic lavage. Endoscopic lobar and segmental saline lavage is beneficial for postoperative patients who cannot clear their secretions on their own. 4. Mucus suctioning. Retained thick, tenacious mucus secretions can be suctioned at the bedside with minimal discomfort for the patient. 5. Hemoptysis causes. While chronic bronchitis is a common cause of hemoptysis, carcinoma should be considered, especially in patients over 40 with a significant smoking history or persistent episodes of hemoptysis, and those with abnormal chest radiographs. 6. Assessment with normal radiographs. In the presence of normal chest radiographs, malignancy should still be considered under specific conditions like age over 40, significant smoking history, or persistent hemoptysis. 7. Bronchial carcinoid and stricture. Hemoptysis accompanied by a wheeze or atelectasis could also be due to a bronchial carcinoid or inflammatory bronchial stricture. 8. Comprehensive evaluation for carcinoma. An abnormal chest radiograph suggesting carcinoma necessitates a detailed evaluation of the entire tracheobronchial tree. 9. Indications for bronchoscopy. Bronchoscopy is indicated not only for diagnosis, but also for managing lung abscesses, and in cases where conservative therapy fails, it may involve bacteriological sampling and placement of a pigtail catheter. 10. Foreign bodies and neoplasms. Bronchoscopy can uncover obstructing neoplasms or foreign bodies and is sometimes used therapeutically to remove inhaled gastric contents, although its efficacy in this regard is debated. 11. Post-inhalation injury. Following inhalation of smoke or caustic fumes, bronchoscopy allows for a quick assessment of tracheobronchial mucosa damage and can be repeated to debride necrotic mucosa and inspissated secretions. 12. Progressive inflammatory response. The inflammatory response from inhalation injuries may worsen over days, potentially leading to delayed airway obstruction. 1. Cystic fibrosis management. Routine bronchoscopy for cystic fibrosis patients, once common, is now largely replaced by vigorous physiotherapy and mucolytic agents, though aspiration may still be needed for thick secretions. 2. Post-transplant surveillance. The role of bronchoscopy in evaluating fever of unknown origin or pulmonary infiltrate post-lung transplantation is well recognized. However, the need for routine surveillance biopsies remains controversial. 3. Surveillance schedule. TRULOC recommends routine surveillance bronchoscopies with biopsies at specified intervals post-transplantation to detect acute rejection and silent cytomegalovirus pneumonia. 4. Detection and treatment. Early detection and treatment of acute rejection and infections are believed to decrease the risk of chronic rejection. 5. Debate on risk. Contrary viewpoints exist on whether early stages of acute rejection or viral infection in asymptomatic patients significantly lead to more serious conditions. 6. Gold standard diagnostic tool. Despite advances in gene and immunologic monitoring, fiber optic bronchoscopy remains crucial for diagnosing acute pulmonary allograft rejection or infection after lung transplantation. Airway trauma assessment. Bronchoscopy is indicated for suspected airway trauma with symptoms like wheezing, hemoptysis, and subcutaneous or mediastinal emphysema. Early diagnosis and repair are crucial. 8. Bronchoscopic techniques. Transbronchoscopic biopsies, cytologic brushings, transbronchial needle aspiration, TBNA, and bronchoalveolar lavage, AL, are standard procedures that endoscopists should be proficient in. 9. Safety and complications. Even severely ill patients can safely undergo bronchoscopy in an appropriate setting with an experienced endoscopist. Airway bleeding is a significant complication. 10. Bronchoscope specifications. Standard flexible bronchoscopes vary in size and functionality, ranging from those suited for pediatric patients to those designed for adult tracheobronchial tree examination. 11. Video bronchoscopes provide larger, higher resolution images than standard scopes, but require a video processor and monitor. They offer improved diagnostic and therapeutic capabilities. 12. Instrument variety. A variety of flexible bronchoscopes should be available to an expert endoscopist to ensure diagnostic and therapeutic versatility. These scopes are usually fully immersible and often autoclavable.